Okay, so I'll talk about the first of those big themes that we identified through our survey and discussions. And this is challenges around assessing the clinical effectiveness of a treatment, COVID-19, or a diagnostic test to test for the infection. So going in order of the kind of biggest sub-themes, 22 responses related to internal validity, the internal validity of the clinical effectiveness evidence. What we mean by internal validity is anything that reduces our confidence in the clinical effectiveness of medicine. So we might see the results of a clinical trial for a COVID treatment, and that says that this will reduce hospitalizations by 10%. But there might be lots of things going on in that trial that mean we're actually not confident about that 10% at all, and that 10% figure could be wrong, it could be very wrong, and so that's what we mean when we say internal validity. And so the kind of things that fall under that category were particularly during the first year or two of the COVID-19 pandemic, many of the clinical studies were reported as things like press releases or preprint articles, essentially in ways that hadn't gone through the usual academic process of peer review. Now, that's a really rigorous process generally, and it can be quite slow. So you can see that there was during an urgent pandemic, there's a need to get evidence out there very quickly. So it's understandable why some companies and some researchers might skip that step and just got their research out there without that peer review. The flip side of that is peer review exists for a reason. It exists so you get independent, external, expert eyes on your research to understand the quality and ask questions and make sure it's as good as it can be before it gets published. So there was an issue there. We're not used to being presented by, pinning our health technology assessment on data in a press release, but we were presented with those situations during the pandemic. Respondents advised that many of the studies in COVID-19 patients were subject to small sample sizes. Now, that's quite an obvious one, that if you only have a small clinical study, 10 patients, 20 patients, then the results of that are naturally much more uncertain than if you had a study in 2,000 patients. So that was an issue. We also heard that there was a lack of randomization in much of the clinical evidence for COVID technologies. Now, randomization is when you join a study, you will either be randomized to the treatment of interest or the control arm, perhaps current care or a placebo, and that decision is taken out of your hands as a study participant. You agree that you may get one or the other, and it's done at random. The benefits of randomization are that you should ultimately have two groups of people that look very similar in terms of the age mix, gender mix, sex mix, all these things that could potentially affect health outcomes. But early on in the pandemic in particular, there were quite a lot of observational studies, single-arm studies, essentially clinical evidence that didn't have that formal randomization process. And that just means that there is a higher risk of bias. You can see from the fourth bullet there that the result of the study, that figure I mentioned before, that the treatment is 10% better at reducing hospitalization risk, that 10% could have been influenced by other things that randomization would have ironed out. So yeah, this was a really, we had 22 responses under this category, that essentially any of these would limit the confidence we can have in the clinical evidence.
Can I ask about internal validity and the lack of peer review? Because does this include results from clinical trials which were not yet published after a peer review in a scientific paper, but they could still have been reviewed by, for example, the MHRA in the UK or other regulatory agencies? And sometimes the conclusions of this evaluation are not public, but I think they made efforts to publish faster than usual. So would you consider reports from a regulatory agency an equivalent of a peer review or not?
Yes, academically it's a different thing, but yes, I think we would see that if a regulator has scrutinised the data and scrutinised the evidence and come to a view, we would consider that to be a form of peer review. I think most of the responses we received from the survey on this topic were more relating to companies publishing their study results as a press release. And the formal publication was months down the line, but all we had to go on was the press release on a website, which doesn't go through that, hadn't been through the regulatory process or any process so far.
And this because most of HTA agencies started their assessment procedure in parallel to regulatory agencies based more or less on the same publications, the same evidence.
Yes, which is not what we're used to. We're used to seeing more mature evidence than that has been through a more robust process.
Okay, thank you.
Another big cohort of sub-themes that were challenging when it came to assessing clinical effectiveness related to an immature evidence base. And by that I mean many clinical studies were reporting results at short-term endpoints. So we'd have studies producing results after 28 days. So the main outcome is 28-day hospitalization discharge rate or 28-day mortality or something like that. Now that's very short-term, 1 month, and for some treatments or acute treatments that might be appropriate, but as an HTA agency, we generally need to at least try and understand more medium or longer term outcomes. So we were presented with a lot of short-term evidence. We were also similarly presented with a lot of interim study results. So companies may have run a trial, it might be a 1 year or 2 year trial, but they're reporting interim results after 2 months, 6 months. And if that's their interim reporting, that's what we have to go on. But we know that if we wait a bit longer, we'll have more data, we'll have more robust information to base a decision on. The problems here are that the problem with that in particular is that during the early pandemic in particular, things were changing quite rapidly. Scientific understanding was changing, clinical practice was changing as we learned more about, as the scientific community learned more about the condition. And so there was a real risk that if we base a decision on an interim study result after 4 months, knowing that actually in 4 more months, there'll be another report, there's quite a high risk that actually the decision we make today might be proven out of date in a relatively short period of time. So there's a risk there between evidence was coming out very quickly and at short-term intervals, and making a decision early is more uncertain, but it was necessary because of the urgent situation. The risk there, the trade-off is there's a higher risk of being wrong, essentially. The early results not being enough, not being good enough for us to extrapolate to long-term outcomes, or just being quickly overturned as scientific understanding and practice changes. This comes back later as well when we talk about cost effectiveness, but essentially a lack of long-term data. And at this point in 2011, long COVID was and post-COVID syndrome was still only in their infancy of being understood. So there was a real concern about what does COVID mean long-term, and what are the treatment outcomes longer term. "13 responses related to external validity. Now this differs compared with internal validity, which is about how confident can we be about the results of this study. External validity is more focused on this study was conducted, it had a certain design, it was given to a certain population of study participants. What does that mean for us? How generalizable are those results to our setting? How replicable is this study if we did it again?" So there were, like I said, there was lots of lots of clinical evidence was quite rapidly being produced in the first 2 years of the pandemic. They had different study populations, so studies would be in hospitalized patients, some would include patients in intensive care, some would not include those. Some would include people who were having mechanical ventilation, some would not include those. So the real mix of what study populations looked like. Studies have different designs, so some were adaptive trials where they could kind of, because understanding was changing so quickly, they could kind of change what was happening in the trial as over time, rather than sticking to a rigid fixed protocol from the start. There were different study settings, so there were lots of studies being put out from America, all across Europe, many in the UK, many multinational studies. And because of the sort of changing nature of scientific understanding, and I mentioned before that clinical practice was changing quite quickly, different studies, depending on when they started, had very different control arms. So very early on, for example, corticosteroids like dexamethasone might have been the intervention of interest, but it quickly became apparent that they were quite effective. So things shifted to be dexamethasone was a part of routine care, and that became the control arm in many studies. So from an HTA organisation perspective, we're presented with this raft of clinical evidence for different interventions in slightly different study populations, sometimes very different. Sometimes the designs looked a bit different. Sometimes the study jurisdictions and settings look different, and sometimes the control arms weren't comparable. So how do we, pick through that? How do we understand which of these things is most relevant to our decision today, about which of these studies is most relevant to us to make a decision about this intervention? Or how do we even go about combining all of this evidence to get one really good estimate of how good the new treatment is? That's really difficult. We're much more commonly presented with a single key trial that broadly matches the indication of the licensed population, and that's what we focus on. And this was very different. 10 responses we categorised as just reflecting that there was generally a lack of evidence in the first year or so of the pandemic upon which to conduct a robust assessment. So this kind of links back to the question earlier about the link between HTA decision-making and regulatory decision-making. Certainly, traditionally, HTA decisions have required more longer-term, robust, and ideally randomized evidence, whereas we're seeing a trend generally in regulators to accept different kinds of evidence. So there was a feeling that in the first year or so of the pandemic, the evidence quality just wasn't sufficient to make a reimbursement decision like we used to doing. And lastly, on clinical effectiveness evidence, on assessing clinical effectiveness, there were some concerns about the study endpoints that were being used in the clinical trials and the clinical studies that were being conducted and reported. Now, a study endpoint is the thing, the outcome, the clinical outcome that an investigator, a researcher focuses on to understand whether the intervention is actually good or not. So it might be discharged from hospital after 28 days. We think the intervention might be better at that. More people might be discharged quicker. So that's our endpoint of interest. Now, there was we heard from agencies that there was an extensive use of surrogate outcome measures. What I mean by that is traditionally, HTA processes like to try and get an estimate of what's the impact of this intervention on quality of life and on life expectancy. They're kind of crucial hard outcomes, if you like, that generally health systems are happy to pay for. We want people to live longer and live better lives. But we were being presented with lots of studies, particularly going back to the short-term issue, lots of short-term studies where the only outcome they were reporting was something like time to discharge from hospital or avoidance of admission to ICU, intensive care. Now, those are relevant outcomes. They're relevant to the clinic, they're relevant to clinicians, they're relevant to patients. But deciding how much they matter in terms of how much a health system should pay for those outcomes was difficult, because we kind of want to extrapolate from those surrogate outcomes to the harder outcomes like quality and length of life, and that's difficult. That's always that's a continual challenge, not only in COVID. We see that in things like cancer treatments, where a trial might report the outcome, the study endpoint might be progression-free survival, which is an important outcome, but it might not be really obvious how that links with overall survival, long-term survival. So we're constantly battling in different conditions, different disease areas with the issue of surrogate outcomes, and it was really prominent in early COVID-19, partly because the studies were generally very short-term.